Greetings everyone, my name is Puruk Patel and I'm a fourth year medical student at NSU, Florida. This presentation is on the successful use of steroids to treat hearing loss in Haemophilus influenzae type B meningitis. Starting with a brief introduction, bacterial meningitis in adults is most commonly caused by strep pneumoniae, Neisseria meningitis, and Haemophilus influenzae type B, or HiB for short. The Infectious Disease Society of America, or IDSA, guidelines recommend using adjunct corticosteroid treatment only for pneumococcal meningitis, but state that the evidence is insufficient for other bacterial etiologies. This case, however, highlights the successful off-label use of corticosteroids for treatment of hearing loss secondary to HiB meningitis, which is not part of the IDSA guidelines. For a case description, we have a 73-year-old female with no significant medical history who presented to Largo Medical Center with dry cough, malaise, altered mental status, and hearing loss 2 days after returning from Europe and having exposure to sick contacts with upper respiratory symptoms. On admission, she was septic with a temperature of 100.1, heart rate of 111, and white blood cell count of 24.3. Blood cultures were positive for HiB, and bilateral pneumonia was found on chest X-ray, as seen in figure A in the middle panel. Initially, pneumonia was suspected as a source of sepsis, and she was treated with IV fluids, acetaminophen, ceftriaxone, and azithromycin. The ceftriaxone dose was then increased and vancomycin was added when meningitis was suspected on hospital day 2. CSF studies were taken and showed high neutrophils, high protein, and low glucose, which are consistent with bacterial meningitis. A CT head was unremarkable. Around this time, hearing loss was also noted, and prednisone at 60 mg daily for 7 days was initiated following an ENT consult. An MRI was done on day 6, shown in figures B and C, and demonstrated normal auditory canals as well as intraventricular hemorrhage and left ACA territory ischemia, which was deemed to be likely from meningeal inflammation rather than a vascular cause. In figure B, you can see the left meningeal enhancement, and in figure C, you can see that there is no masses in the auditory canals. By day 7, hearing and neurological deficits had improved, and CSF and blood cultures were negative. She was discharged to inpatient rehab in an improved and stable condition. This case demonstrates the successful use of prednisone for hearing impairment secondary to HiB meningitis, with minimal treatment side effects or residual hearing deficits. Hearing loss is a common and debilitating complication of meningitis, regardless of the microbial cause. However, there are limited adjunct therapy options for non-pneumococcal pathogens, as per the IDSA guidelines. This vignette highlights an off-label use of steroids that is worth considering with a careful risk-benefit analysis in patients with meningitis. There is a need for further research into steroid therapy in non-pneumococcal meningitis to provide adequate evidence for guidelines. Thank you for listening.